Hey guys, am I audible, visible? Good evening. So how was your day? I hope your day are good, and I'm think quite a few of you will have your first exam on Monday. How many of you are here who is having exam on Monday? Sai, if you're here, yes, definitely I'll talk about hypersensitive reactions as well. Fine. So here today, I'm titling it as Immunology and Genetics. I'm going to discuss more of immunology. I'm leaving genetics. I'll definitely take one more lecture. I'll let you know when the timing is on a few topics like bleeding disorder. One thing which Samantha asked about cardiomyopathies, and also a little bit about genetic disorder as well. Fine. Okay. So with that note, we'll be talking primarily on immunology. Few topics which in immunology which I feel is important, which might come in an exam: amyloidosis, autoimmunity, hypersensitivity, graft rejection. I am not talking about HIV, but I'm 100% sure you must have read in microbiology about HIV, in pharmacology about HIV. That I'm sure you'll be able to write an essay or a short note if it comes in an exam. Fine. Definitely, Samantha. Like I said, I'll take one more class, though it's not scheduled. I'll ask them to schedule it, and I'll cover the bleeding coagulation disorders, your cardiomyopathies which you asked, and also a little bit of genetics. Fine. Good evening, ABCD. So let's start. So first is amyloidosis. Like I said, general path does not have a very perfect template. You need to design something. So basic thing is write a definition, write what is causing them. If there's any subtypes, the way to diagnose, Gaussian microscopy. That's it. Fine. So amyloid is a condition where the most important thing is extracellular fibrillar proteins, which is responsible for damaging the tissue wherever the organ it is, and also which will result in functional compromise. This is a definition which is there in Roberts, right? So if I have to have something which is having a deposit, there are only two things, like we must have already read. So the pathogenesis is pretty simple. One, I have to have either excess production of a normal protein, okay, or I have to have a reduced destruction or a reduced removal of an most likely a mutated protein, because a normal protein generally will be removed properly, right, by the ubiquitin proteasome pathway. I have an excess production or a reduced destruction. That's what is going to cause us, fine. Okay. So the different types of amyloid, Robbins classifies them as generalized, localized, and hereditary amyloidosis. I'm just classifying them based on the amyloid protein. If you want to classify as generalized, localized, hereditary, go ahead. Fine. Generalize your AL, AA, all will be generalized. Localized, I'm sure you know that ACAL, your AIAPP will be there in thyroid, and also your A beta in case of brain and Alzheimer's. Localized. Hereditary, AA and ATTR are types of hereditary amyloidosis. Fine. So we'll discuss about amyloid and which disease we are going to see, right? AL amyloid, it's undoubtedly the most common type of amyloidosis, and you see in patients with multiple myeloma. Again, most likely amyloid will be mostly asked in a short answer, which this is more than enough what you're discussing. If they are asking in a long answer, write that multiple myeloma is a neoplasm of plasma cells where you have more immunoglobulin. More immunoglobulin equal to more light chain, which will get filtered and will get deposited. That's all, right? Good evening, Aniket and Sarkar. Fine. So AA amyloid, I have two different types. One, I can see them in case of a chronic inflammation. Any chronic inflammation can result in AA amyloid, because AA is a serum amyloid A protein, which is an acute phase reactant. Fine. Okay. Yes, Samantha. Alzheimer's we'll see here A beta soon. Fine. In that you'll have A amyloid. We can be rheumatoid arthritis. It can be tuberculosis. Any chronic inflammation, Crohn's, ulcerative, whatever comes to your mind. Right. Again, A amyloid can also be seen in patients with hereditary. So if it's an hereditary A amyloidosis, we have a disease called as an hereditary Mediterranean fever, where I'm going to have mutation in the pyrin gene. Okay. Thank you, no notice. Fine. So when you have the pyrin gene, so automatically this pyrin gene will increase the interleukin 1. Once it increases the interleukin 1, which is going to increase inflammation, which also causes AA, right? So I have AA, I have both your chronic inflammation related and also an hereditary type, where I have hereditary Mediterranean fever, mutational gene, more inflammation, more and more deposit. Fine. Perfect. Then A beta to M, you will see in patients with chronic hemodialysis. Any patient with chronic hemodialysis, beta 2 microglobulin is a component of MHC1. It gets deposited over the period of time, not being properly cleared by the kidney, and I'll have AA amyloidosis. Fine. Good evening, Mamesh. ATTR, again, I have two things. Same like AA, ATTR can be a part of senile systemic amyloidosis. It's senility. So over the period of years, though the protein produced is normal, my protein removal mechanism might become weaker, right? That's one. ATTR, a senile systemic amyloidosis. Again, I have a type called as an hereditary familial amyloidotic polyneuropathy. Fine. And hereditary amyloidotic polyneuropathy. Okay. So that there also I'll have your AA amyloid deposit. It's a neuron related thing. So where here I'll have, it's hereditary, right? You'll have mutated transthyretin. that also will cause the same, fine. So AA and ATTR, both of them have two different conditions. One is acquired, one is inherited. Same here, chronic inflammation, senile systemic, right? And all these three are localized amyloidosis, fine. So ACAM, calcitonin, which disease? Can you guys tell me? A beta, the precursor protein is amyloid precursor protein that breaks to form A beta. So an amyloid precursor protein APP, which breaks to form A beta, and that is seen in case of an Alzheimer's disease in CNS, right? In brain parenchyma, right? Okay. Too many things, Aniket, going behind my head. Ping me in Insta, I'll definitely take care of it. Fine. Okay. And then we have medullary carcinoma of thyroid. Okay. I'm trying to learn, so too many things might be a bit of difficulty for me, right? Perfect. Not medulloblastoma. A beta will see in medullary carcinoma thyroid. I hope it's a typo, Samantha. Fine. AIAPP will be seen in case of in pancreas. In pancreas, you will have them in type 2 diabetes mellitus. Fine. Okay. Okay, fine. So these are the different types of amyloid and different things. The way you classify based on Robbins or based on the AL protein, whatever is comfortable with you, go with that. Fine. Okay. Then you come to organs. Gross will be this. The prominent thing here, everywhere gross, there will be an increase in size of the organ. That is by default the common one, because I'm having a deposition of a structure, be it in tongue, macroglossia, or any of the organ will have organomegaly. Will have hepatomegaly, will have splenomegaly, kidney size will become bigger, heart size will become bigger. Tongue also I'm going to have macroglossia. Macroglossia is one of the classical finding seen in patients with amyloidosis. Fine. Kidney, I can have either a normal size in the start, which might increase to an enlarged kidney, increase in the size of the kidney. Later on, at the terminal stage, what will happen? In the terminal stage, in the end stage, the kidney will shrink for sure. There will be a reduced in size of the kidney because the amyloid always deposits the perivascular area, which compresses the blood supply, causes atrophy of the kidney, right? Kidney is undoubtedly the most common organ involved in amyloidosis. A question, if it's a clinical scenario which says that enlarged kidney, no cyst, no tumor, but causing renal dysfunction, the answer most likely should be amyloidosis. That's a clue for you. Enlarged kidney, no cyst or tumor, think of amyloid, right? Spleen, based on the deposition of spleen, be the red pulp deposition or an white pulp deposition, we have different types of spleen, right? So what's the name for the white pulp deposition? White pulp will be like dots, red pulp will be like a lake, so we call them lardaceous spleen. It's a deposit which is seen throughout the spleen, and here white pulp will be like dot, we call it sago spleen, right? So in a viva, if they ask, can I differentiate sago spleen from a miliary tuberculosis on gross? The answer is no. Both of them will look more or less similar. The only way I can differentiate them is I have to do a microscopy. Amyloid will look different on microscope, and obviously TB will look different on microscope, right? Perfect. In parts, they get deposited, fine. Liver, again, perivascular area, you'll have hepatomegaly, that's by default. That's first thing which you have tried for every organ. It will be accumulated in the space of Deci. In the space of Deci, it gets accumulated, right? Perfect. And heart, again, heart or cardiac amyloidosis is the most common cause of death in amyloid because it's difficult to treat a cardiac amyloidosis. Amyloid does not have a treatment. Kidney fails, I have dialysis, or I can replace the kidney. Heart replacement is not that easy, and it will cause arrhythmias, which may cause sudden cardiac death, and restrictive cardiomyopathy, you must have read, right? So cardiac dysfunction is by default there, and will be the most common cause of death, and the deposit area is subendocardial space. Fine. The subendocardial space, you'll have deposition of amyloid, which might result in the death of the patient. Fine. So how do I diagnose? Diagnose by default is based on biopsy. Biopsy could be based on the organ, specific organ. If I'm going to have a cardiac amyloidosis, I can see only in the cardiac biopsy. Thyroid, I can see only in the thyroid biopsy, or systemic. Fine. Okay. What question, Samantha? Please tell me. Amyloidosis question means, or I can have an abdomen fat pad aspirate. You can write both abdomen fat pad, or you can write an rectal biopsy. Both are good enough. We know the concept. The concept is both of them will have excess amount of capillaries or blood vessels because amyloid deposits in the perivascular area. That's why these two areas are chosen because of its abundant vascular network. Be it a capillary or a vein, I need vessels here. Fine. Okay. I told Samantha, if you have a question which says an enlarged kidney, this is not only for your final year, second year exam, throughout life. An enlarged kidney, when there is no cyst or a tumor or a cancer and having a renal dysfunction, the common cause will be amyloidosis, because kidney will not become bigger in size. It might shrink, it will not become bigger in size. If there is a cyst, yes, explainable. If it's a cancer, explainable. Renal dysfunction of an enlarged kidney in the ultrasonogram, no cyst, no tumor, first possibility, think of amyloid. Fine. Okay, now let's come to this. So once you taken biopsy, obviously the first thing you're going to do in H&E. In H&E, amyloid will be pink in color and most likely in the perivascular area. I am not saying it will be only in perivascular area. Perivascular area is the first place where it gets deposited. Pink, many things are pink in color. So I obviously need a stain. So in stain, I'll tell two things. What's the stain used for amyloid? Can anyone tell me? There's one stain which is definitely everyone knows. Congo red, right? So the common stain which I'm going to use in practicality is Congo red. But if you have a 2-mark answer or a 3-mark answer or a Viva where they say that give me more stains than Congo red, though Congo red is the only one practically used, PAS can be positive because amyloid is a protein deposit, right? Obviously, thioflavin can be positive. Okay, thioflavin, yes. PAS, we have crystal violet, that can be positive. If they ask you, give me 4 stains for amyloid, these can also be useful, right? Definitely, so I'll do that. Okay, H&E obviously can be done, Samantha. Fine. So once I do it in Congo red, again I have two possibilities. On a light microscopy in Congo red, I will have your salmon pink color. It'll be salmon pink color. Again, pink and salmon pink might be difficult to differentiate. Then I go for your polarized light. So polarized light, you're seeing the image here. You have the classical. You won't forget this, right? An apple green birefringence. That's a classical finding seen in case of an amyloidosis, fine. So this is for diagnosis of amyloid, more than enough. Okay. If you want to score extra mark, there is a confirmatory test for amyloid. Amyloid is a beta pleated sheet. What is the confirmatory test for any protein structure? If you have to confirm, confirmatory test or the diagnostic test or the most specific test for amyloid undoubtedly is your X-ray crystallography. X-ray crystallography is the only one which will give me the protein structure. And in X-ray crystallography, you will see the classical beta pleated sheet of amyloid. Okay, they are non-branching beta pleated sheets, right? That's the perfect thing which can help me to identify. Again, this might come in a Viva if you answer everything. Right? Somewhere they have to say that I am superior, right? They'll definitely ask you a question. If you answer that also, be ready to get more and more questions. It's completely fine. At one point of time, no, let the examiner win. Our goal in the exam is not to demean the examiner, to pass the exam, right? At one point of say no, so the examiner is happy and they'll give you the best mark possible, fine? Okay. Treatment, as of now, there is no approved treatment for amyloid. If you want to write this word, write. There are few experimental treatment which are called as amyloid breakers, but not very much useful. They are then still in early phase of trials, fine? That's in short about amyloid. Amyloid, if it comes in a long answer, everything what we read in these two tables, elaborate, because every line in these tables can be having easily 2-3 points. We have 8 different types of amyloid, 2 points for each, and organ 2 points for each. That's more than enough for you, fine? If it's a long answer. If it's a short answer, please don't explain. It will be a waste of time for you. Okay. Now let's go to a template of SLE and Sjogren's. We'll read two things just based on template, because any autoimmune disorder comes to you, the template is the same. I need 3 inputs for every autoimmune disorder to happen. One is genetic. The second is your environmental thing. The third is obviously your altered B cell and T cell tolerance. By default, I need everything, right? So whatever autoimmune reaction comes, these 3 components should be there. You need a definition. This is definition from Robbins, or you write whatever comes to mind. SLE is an autoimmune disorder with anti-nuclear, anti-double stranded DNA antibodies, and you'll have deposition of immune complexes binding to the antibody, which will cause the damage. So if it's an immune complex deposition, can anyone tell me what's the type of hypersensitivity you see in SLE? It's classical. So classical type 3 hypersensitive reaction, right? If you want, you can write that as well. A simple definition, you need not be word by word correct from Robbins, Sjogren, Ramdas Naik, whatever book you read. That doesn't matter at all. I want you to understand, okay, you know what is SLE, that's more than enough. SLE is an autoimmune disorder affecting mostly women. ANA, double-stranded DNA, vasculitis, type 3 hypersensitivity. Enough for me for a second year student. I really don't expect more than that for a second year student. You are very well informed, you are very well learned. Be confident, go and write the exam, fine? Okay. So like I said, for every autoimmune disorder, I need three inputs. One will be genetic. So when I say genetic, at least one HLA if possible, or one gene if possible, remember, right? And one environmental input. And one will be, this is static. You'll have an altered B and T cells tolerance. This will not change. Tolerance is a mechanism by which I will stop autoimmune disorder, right? Samantha, the reason is one thing which has been there for years is estrogen kind of activates the antibody production, the female hormones. And the second thing which is newly coming up is men are more clean because of hygiene hypothesis. Sorry, women are more clean. So hygiene hypothesis suggests that women have more risk of autoimmune disorder, right? But tell the first answer. Hormones kind of activate and increase the antibody production, right? This is constant. For almost every autoimmune disorder, this is constant. Again, I can make one more thing constant. For almost every autoimmune disorder, except a few, the trigger, the environmental trigger, mostly is a virus, right? COVID is an example. The most likely trigger is a virus. If I'm talking about an GI, I talk about bacteria. If I talk about an oral cavity, Epstein-Barr virus could be a trigger. Whatever organ it is, suggestive virus could be a trigger. Write that. Most of the time, not always. SLE is not triggered by that, but mostly the trigger is a virus. And genetic, if you know, right? Otherwise, just give a very random thing. Twin studies proved that they are genetically related, because that's a very low level of evidence. But if you know what is the thing involved, write that. Fine. Now let's go to SLE's pathogenesis. Same three things. So for genetics, with respect to HLA, DQ locus increases the production of your anti-double stranded DNA. That's one. And you'll have an early complement deficiency. Okay. The early complement factors deficiency will definitely increase the risk of SLE. Early complement is C1, C2, C3, C1Q, all those things. That's early complement factor. Up to C4 is early complement factor. Fine. Okay. Then I have the environmental trigger. Environmental trigger for SLE is excess exposure of UV rays. That's one. And obviously one more guy, drugs. I'm sure you know the drugs, right? Hydralazine, D-penicillamine, right? Those drugs. The mnemonic of SHIP is there. You will never forget that. So drug is one of the important trigger, drug-induced SLE, fine? Okay, Aniket, remember this. Autoimmune disorder is an inflammatory disorder. The reason why I call it autoimmune is it's directing against my own body. Any disorder in my body except for cancers and genetics are all inflammatory disorder, right? Here also, SLE is autoimmune, right? But the outcome is inflammation, vasculitis. Outcome is different, etiology is different. Every autoimmune disorder outcome will be inflammation only, including SLE, Sjogren's, whatever it is. Inflammatory bowel disease also will come under the same spectrum, right? And here, then we have your, again, altered B or T cell tolerance. That's definitely going to be there, right? If you want to add one more, add that increased production of interferons. Type 1 interferons, that also is one of the important triggers in SLE, which comes from the immunological thing, fine? Okay. Now we have all these things, right? Genetic, environmental, and immunological, right? So whenever there is an excess amount of UV rays, there will be excess amount of apoptotic bodies. This excess amount of apoptotic bodies is not removed. Not removed for the reason I have an early complement factor deficiency. Okay. So because of that, I am not removing that, because obviously I need the opsonization for an apoptotic body to happen. So it keeps on staying there for a long time, right? So since they are not removed, when I have an altered B cell, the B cell and the T cell will react to the DNA in the apoptotic body, or the nuclear antigen in the apoptotic body, right? So when the B cell T cell reacts to the nuclear antigen in the excessively not removed apoptotic body, I'm going to have an antibodies to DNA. I'll write just ANA because ANA is the most sensitive one. I'm sure you know that. ANA will be there, right? Anti-nuclear antibodies, fine. So this anti-nuclear antibody will bind to its antigen, that's the nuclear antigen. Once it binds, this immune complex will be taken by my antigen presenting cells, and this antigen presenting cells, because of increased interferon production, will amplify the antibody production. And this amplified antibody production will go into circulation and will act as an immune complex. From here onwards, it's not autoimmunity, right? Immune complex, what type of hypersensitivity? Type 3, right? Samantha, I think I messaged you somewhere that endocarditis means anything which is inflaming the endocardium. Rheumatic carditis isn't a type of endocarditis. Infective endocarditis is a type of endocarditis. Liebman-Sachs, your non-bacterial thrombotic. If endocardium is involved, I can call it endocarditis. All the 4 vegetations what we read, all of them are endocarditis only, fine. So once I have the immune complex, it will cause vasculitis. It will deposit, it will cause vasculitis. Vasculitis is the one which causes the damage, right? So every autoimmune disorder, write this. This will easily take half a page. And whatever we are discussing here is absolutely correct. No one can say wrong, right? It's genetic, environmental, altered tolerance. Because of that, I'm having an antibody production which causes the damage. And this outcome is based on what is the predominant cause. SLE type 3. Sometimes when I take rheumatoid arthritis, it's type 4. It's T cell mediated, right? Based on that, the outcome will change. Otherwise, rest everything template is same. Fine. Okay, let's go to diagnose. One of the symptoms is Sjogren MD. That's a classical, all the features of SLE. If you remember Sjogren MD, great. Otherwise, you definitely know how to diagnose, right? SLE, age, most likely middle-aged, can be seen in elderly as well, right? And most likely more commonly seen in women. What's the classical symptom of SLE? You will not forget that, right? That's malar and discoid rash. Fine. That's your MND, right? Sjogren MD. It's type 3 hypersensitivity when my immune complex has to deposit. So can I say wherever there's filtration force, it will deposit more? Obviously, it will deposit more, right? So any serosa will have a filtration force, right? So that's your S, serositis. When I say serositis, pleuritis, pericarditis, all of them will have, right? Serositis, right? O for your oral ulcers. Again, oral ulcer, squamous epithelium. Like skin, I have photosensitivity here. I can have the same thing here which causes oral ulcer, right? SOA for arthritis. It's not just malar and discoid rash. I can have photosensitive reaction to any part of the skin. Malar discoid is more common because it's very exposed to the sun whenever I go out, because the trigger is the sun exposure. Fine. Okay, that's your serositis, oral ulcer, arthritis, photosensitivity. Fine. It's produced against nuclear antigens. It's produced against your DNA. But when I see why I'm having autoimmune hemolytic anemias, imagine there's WBC, lots of WBC in my circulation, and I'm having antibodies there. So I'm having a inflammatory condition in the, what to say, in your blood circulation, and there's an autoimmune reaction. So if by chance an RBC ruptures due to some problem inside the inflammatory place, it'll start producing antibodies to that also. That's the reason you'll have hemolytic anemia by default, right? That starts for the B, blood disorders. I can have just write cytopenias. You need not go and explain why hemolytic anemia. Anywhere, I'll have anemia, thrombocytopenia, and also your leukopenia. Cytopenia is very, very classical for SLE, right? B, R for your renal disorders. If it's a long answer, write all the different types of lupus nephritis. Otherwise, just write, it will definitely cause lupus nephritis. We know more about lupus nephritis. We did read them in the glomerulonephritis disease, right? Okay, and AI for autoimmune or autoantibody level or your immunological phenomenon. Okay, so immunological phenomenon where I can write your ANA, which is a very sensitive antibody. Can anyone tell me what are the specific antibodies in SLE? There are many antibodies in SLE, right? Most sensitive is ANA. The most specific is, there are two things which you should definitely write: antibodies to double stranded DNA or antibodies to Smith or SM antigen. These are specific ones for SLE. SLE will also have anti-Rho, anti-La, SSA, SSB, it will have, but these are very specific, that's all, fine. Okay, right? That's A for AN, and N obviously is neurological disorder. Neurological can be neuropsychiatric manifestations or inflammation and vasculitis in the brain. Okay, perfect. Okay, so that's your clinical examination or clinical features. Sjogren MD, remember that. That's more than enough for you to write about clinical information, right? Treatment, I'm not going to talk about the treatment. You know more about the treatment, how to do it, how to take care of that. If it's drugs, remove the source, stop it. If not, various amounts of steroids, corticosteroids, very high immunosuppressive agents, but still SLE is fatal. SLE by default will cause damage to the kidney, which will kill the kidney, right? That's in short about SLE, right? You know more about SLE. If SLE comes in a long answer, please wait for 2-3 minutes. You read in multiple places SLE. Take all that. Write cardiac, Libman-Sachs endocarditis. Add it. Write lupus nephritis. The full house effect, what we read. It will affect your glomerulus, tubule, peritubular capillaries as well as the arcuate arteries. Write that. We read SLE in different places. Collate everything if it's a long answer. Otherwise, this should be more than enough. Fine. Before autoantibody, A and I. Okay, autoantibodies or an immunological phenomenon. So I can either measure them in the form of titer, or you have a, what is it, the green and the black picture, the immunofluorescence. Fine. No. Sarkar, like I said, no, like everything, whatever we read in terms of immunofluorescence is never specific. Fine. So speckled SSA, SSB is one of them, right? Anti-Smith will have more of an homogeneous pattern. If I remember exactly, speckled pattern is primarily for your SSA, SSB, Sjogren's, fine. Anti-Smith antibody should sorry. Anti-Smith also has speckle pattern, homogeneous for your double stranded DNA, right? And also envelope proteins, fine. So pattern of immunofluorescence is not diagnostic. Only the clinical feature is diagnostic. If I have an speckled pattern of immunofluorescence and a swollen salivary gland, my answer is Sjogren's. If I have a speckled pattern of immunofluorescence and serositis, oral ulcer, arthritis, photosensitivity, my answer is going to be SLE, fine. Okay, see, if it's a clinical question, if it's a long answer question with respect to SLE, one, a young individual, okay, SLE can have any of the above stated as a clinical scenario, right? But one thing which is should be there at least for an undergraduate, the malar rash. Malar rash should be there, or I can say, can SLE cause abortion? SLE can cause abortion because SLE, one of the subtype could be an antiphospholipid antibody syndrome, right? SLE is a very big autoimmune problem. I can have multiple other things, right? It can manifest as an antiphospholipid antibody syndrome. It can manifest like that. It can manifest as nephritis. It can manifest as carditis, right? But at least one thing, if I am an examiner, I will say malar rash, engage, two important things at least to think in terms of SLE. Other things, whatever the examiner feels, can go ahead with that. Fine, Samantha? Okay. So Sjogren's, same template. SLE is a very, very big thing, right? See, and one more important thing, if I am having a problem in one autoimmune disorder, is there a possibility I can get one more disease? Because for every autoimmune disorder, I have these three as a problem, right? The main concern is B and T cell. They are abnormal. So if sun is triggering, it causes SLE. If a mumps virus triggers, I'll have a different thing. If I'm having a thyroid problem, I might have Hashimoto, right? So I might have Hashimoto. So most of the autoimmune disorder can have one more autoimmune disorder as well. That's by default the problem with every autoimmune disorder. Like Hashimoto can coexist with rheumatoid arthritis. Hashimoto can coexist with SLE. Sjogren's can coexist with SLE, right? They are more of an overlapping spectrum, but whatever is predominantly manifesting, we treat accordingly. Fine. Okay, Nikhil? Okay, let's go to Sjogren's. Again, there's two lines from Robbins. Sjogren's, by this time you must be sure about keratoconjunctivitis sicca. That's a word I expect in the definition for an undergraduate, right? It's a chronic autoimmune inflammatory disease characterized by dry eyes, dry mouth. That's most important because of destruction of lacrimal and salivary glands, right? So the very simple words, whatever you feel like, write the definition. You need not write the definition as per the Robbins, fine? Okay, again, same three things. Genetic factors, I don't have any strong genetic influence for Sjogren, so you can write that twin studies has shown increased incidence, okay, which means that somewhere there is a genetic etiology. There are few HLA, but not very strong for Sjogren's, fine. Then environmental here, two things. One, viruses. There are many viruses. It said that EBV, HTLV1, right? Your HIV virus can also trigger Sjogren's, and smoking. These are two things which is supposed to trigger Sjogren's, and obviously your altered B and T cell tolerance. Okay, that's by default common for every autoimmune disorder, right? So because of these things, most likely the trigger will be the starting point, which will break an antigen and produce a neo antigen. So the neo antigen, because of the trigger, will, and my T cells and B cells are abnormal, which will produce an auto antibodies to two specific RNPs. RNPs are nothing but ribonucleoprotein. Okay, these are two specific ribonucleoprotein. They are producing the antibodies against, which is your anti-Ro, the older name, SSA is a newer name, Sjogren syndrome A, and anti-La, the newer name is SSB. Fine, and these are going to destroy both your lacrimal and salivary gland. Normally, because these two ribonucleoprotein are more present in lacrimal and salivary gland, so normally I destroy them. Let's assume these ribonucleoproteins, right? Many part of my body can have. If my anti-Ro titers are very high, that's when I'll have extraglandular manifestations like arthritis, lung damage, right? Many damage can happen only when the Ro antigen antibody titer is very high. Normally, these two are the ones which are going to be destroyed. A very simple pathophysiology. Fine. Diagnosis, again, there's something it's seen bit in elderly, not in young age group. Again, most commonly in women. First, the patient clinical symptom will be swollen lacrimal and salivary gland. That will be the starting point, because if I'm having initially damage, there'll be lots and lots of lymphocytic infiltrate, right? Okay, which one, Samantha? And then, yes, obviously in the later stages, you might have dry eyes and dry mouth, xerostomia. You can have salivary gland calculi, salivary duct calculi, that also can be there, right? Like I said, I can have this word you asked for, Samantha, extraglandular manifestations. Okay, extraglandular manifestations will be there when there's an extremely high titers of SSA or anti-Ro. Fine. So they have extremely high titers of anti-SSA. So I will destroy the lacrimal salivary gland. It's too much. So it overflows outside. That time, yes, you can have arthritis. You can have pulmonary lung involvement, which can happen if my titers of SSA are very high. Most of the time, only this much. Similar to your ulcerative colitis. Ulcerative colitis normally is a inflammatory bowel disease. When my titers are very high, can I say ulcerative colitis can cause autoimmune cholangitis? Right? We read about two autoimmune cholangitis, right? Which is related to ulcerative colitis. Biliary cirrhosis or sclerosing cholangitis? Sclerosing cholangitis, right? So whenever my ulcerative colitis titers are very high, it can overflow from the gut, go to the liver and destroy the liver. Same way, here also when the titers are very high, it can overflow and destroy the other things as well, fine? This is my clinical features. This can come in your they won't ask in long answer, most likely short answer only for Sjogren's, fine? Good in history. So when I have this as a clinical feature, then obviously I'm going to diagnose. So diagnosis here, one obvious is an history plus antibody titers in the serum, or history plus immunofluorescence. Okay, like Sarkar said, most likely the immunofluorescence will be speckled pattern of immunofluorescence, because speckle will be seen your anti-Ro and anti-La. That's first. Second, biopsy. Which part you will take biopsy? It's very difficult to take a biopsy of a parotid or go and poke the lacrimal gland, right? So you go for a lip biopsy. Okay, so lip biopsy, where I see the minor salivary glands, because that's easy to take a biopsy, not much of a complication, just pick and go, right? Lip biopsy, what I'll see in microscopy is it's an autoimmune disorder. If your base is strong, pathology is very easy, right? Any autoimmune disorder, what will I see in microscopy? Neutrophils, lymphocytes, basophils, macrophages, plasma cells. Every autoimmune disorder will have only one thing on microscopy: lymphoplasmacytic infiltrate. Okay, now lymphocytes plus plasma cells, mostly lymphocytes in the infiltrate, and there'll be destruction of the glands. So once I have destruction of the salivary glands and lymphocytes and plasma cells, I'll be more than happy to call it an autoimmune disorder. Same, Hashimoto, lymphocytes, plasma cells, destruction of the thyroid gland. Same, your rheumatoid arthritis, lymphocytes predominantly because T cell mediated, and that's going to destroy the synovium, right? All autoimmune disorder will have the same manifestation. It will not change, fine? And that's more than enough for me. And once I'm done, we'll go and treat it, right? But I want you to remember one complication of Sjogren's. there's an increased risk of B cell lymphomas. Extranodal lymphomas, not Hodgkin's lymphomas, or your marginal zone lymphomas, extranodal in your lacrimal salivary gland can happen with this. Fine. Yes, Sanika, that will pain. Right, I'm going to prick and take a bit of tissue. Then they'll definitely anesthetize. They'll suture. Obviously, it will pain. You cannot help that. It will definitely pain. Fine. That's about Sjogren syndrome. Fine. Done. Definition carries at least half a mark. Pathogenesis for 2 marks. Clinical manifestation for 1 mark. An approach to diagnosis and a word about the treatment. Rest of it. 5-mark question. This is more than enough. The most important thing in an exam is how do you structure the question? How do you structure the answer? The knowledge will work when you come out and practice. That's the important thing on a long-term vision. But for an exam, the structure is very important. Please write the structure. You'll know at least 1 or 2 points for every heading. That's more than enough to say it, right? Sai, if you're still there, hypersensitivity, right? Quick run about hypersensitivity, type 1, type 2, type 3, right? Don't worry, Prajwal. Everyone here who's teaching you has crossed the thing. We also in the same phase. You're just in second year. You have an amazing career ahead of you. Don't be scared. If you're scared, you lose the exam. What will maximum happen? They can't do anything. You have essay writing skills. That's what we did for you in school days. We developed the art of writing an essay even if you don't know what any topic about it, right? You know many things about pathology. You will be confident in writing an exam. Fine. So type 1, type 2, type 3, type 4, all of them are due to your adaptive immunity. Type 1 is allergic mediated, IgG mediated. Type 2 is antigen antibody, predominantly IgG, then IgM. Circulating immune complex, which is antigen antibody complex. The prototype is SLE, and this is T cell mediated. Again, predominantly CD4, CD8 to some extent. Fine. Okay, this is what there. Yeah, true. Okay, so these are 4 different types of hypersensitivity reaction. Quick run through of everything 1, 2, 3, and 4 without wasting much of time, right? This is type 1 hypersensitivity. Type 1 hypersensitive reaction, the word which I expect in an exam is it is an immediate hypersensitivity. That's something which I do expect, right? That's one. Second, type 1 hypersensitivity reaction will always have an sensitization phase that will be there. Then a re-exposure, then symptoms. This is the template of almost every allergic response: sensitization, re-exposure, and symptoms, right? There's an image, it's from Google. We have beautiful images, Robbins as well, right? I'll just zoom this. Since both of them are in the same image, I took this, that's all. First exposure, the most common exposure is pollen grains, right? So pollen grains goes to my respiratory tree. Antigen presenting cells of the dendritic cells of the respiratory tree will take them and give it to my T cell, which makes to TH, which one? TH1, 2 or 17. Type 2, it's TH2 response, right? Most likely in type 2, you have TH2 response. That TH2 response will push my B cell to produce plasma cells. If it's an essay question, talk about interleukin 4, interleukin 5, 13. The TH2 will give to interleukin 4, 5, 13, which does all the probability of pushing my B cell to plasma cell, which produces IgE, right? Also the same way, 13 will also cause eosinophils to come, and that will cause epithelial damage as well. This is the first one. So after the first sensitization, the IgE will sit on the FC receptors in the mast cells or the basophils. Tissue basophils are the mast cells, right? Okay. So it's deposits there on the FC receptors and will wait. Only when there's a re-exposure of the same pollen, it will sit on the antigen, causes antigen antibody reaction, causes degranulation. It will not stop with degranulation, right? It will degranulate. It will obviously produce inflammatory cytokines of prostaglandins and interleukins. Interleukins by default is a chemoattractant. So this chemoattractant will definitely produce more new WBCs, right? More WBC and more damage. Fine. Essay question is the easiest one because you already must have read for the inflammatory mediators. So right, degranulation, histamine causes vasodilatation, increased vascular permeability. Interleukins, sorry, not interleukins, your leukotrienes. Fine. Leukotrienes, bronchoconstriction, vasodilatation, increased vascular permeability. Prostaglandin, same, and also your chemotactic factor, right? And more WBC. This what happens, right? This is the template. So once you write the pathogenesis, in every type 1 hypersensitive reaction, I have 2 phases. This happens after re-exposure, right? What's the first phase? We have an immediate phase. So immediate phase starts within minutes of exposure. Within minutes of exposure, it will last for 10-15 minutes, that's all. That's primarily mediated by histamine, serotonin, and all the things which are already preformed, right? And then we have a late phase response that starts beyond 2 hours and can last for up to 24 hours. It's a little bit long lasting, and this is primarily due to the interleukins, the leukotrienes, and the new WBCs which come inside, right? That's in short about the pathogenesis, right? Write this in a straight thing, and maybe in the sites, right, whenever you write mast-cell degranulation, write about immediate, then late. If a question comes on asthma, same type 1 hypersensitivity, same pathogenesis. The only alteration is it happens in my respiratory mucosa, fine. Examples. One example which you should not forget is anaphylaxis. The reason why anaphylaxis is important is there is no sensitization here. If there's no sensitization, it is immediate and it can be dangerous. And anaphylaxis always happens for a parenteral antigen, not an inhalation route or an ingestion route. It most likely happens for a parenteral route, because parenteral route, the load of antigen exposure is more, right? That's why bee sting. It stings directly into my blood circulation. Or drugs, I give directly into blood circulation. That has more incidence of anaphylaxis than a pollen grain or a food allergy, right? Test examples. You can have allergic rhinitis. That's an example. Urticaria is an example, which is skin infection, skin allergy. You can have food allergy, asthma, right? You can have asthma as well. There are many examples. I'm sure you know. You must have also experienced that. Treatment is adrenaline, like Aniket said. Fine. Okay. If you want, and if it's an essay question, we have something called an anaphylactoid reaction. What does oid mean? Oid means like, right? So this is IgG dependent, not IgE dependent. So it's anaphylactoid, like an anaphylaxis. There is, again here also, there's no sensitization. That's why it's like anaphylaxis, but it's not dangerous, right? It's less severe. Okay. So that's anaphylactoid reaction. It's anaphylaxis like, but IgG mediated, but not dangerous, without sensation. That's why I call it anaphylaxis, right? Again, if required, give a word about anaphylactoid reactions as well. Fine. Okay. So what does it mean? One, and what is the routine? Image or a flowchart for the pathogenesis, and what are involved? Few examples. For a 5 mark, this should be enough. If it's an essay, please make sure you elaborate a little bit more. And if they say, they'll already give you a structure. They'll say examples 2 mark, pathogenesis 4 marks, mediators 2 marks. So it's very easy for you to write it. Fine. Okay. Next, type 2. Type 2 is anything, Aniket, anything which can cause allergy can also cause anaphylactoid reaction. Why I'm calling it anaphylactoid is, let's say in future, you see a patient with allergic rhinitis, but IgE levels are normal. Exactly allergic rhinitis. IgG is more. I call it anaphylactoid. It's like an allergy, not an allergy. That's what it is, fine. It came later on. By when we saw patients, some things were not having IgE, but everything else same like IgE. Treatment also same. What do I do? I put an oid and write in the book. That's all, fine. It's all evolution. Maybe in future, if something else happens, we'll evolve more. That's it. Okay. Type 2. Type 2 is antigen antibody reaction. So in type 2, there are 3 subtypes. One is when the antigen is on a cell. Second is the antigen is on a surface. Samantha, it is exactly like allergy. The only difference is it's not IgE mediated. That's all. Fine. Okay. Third, you'll have, it's not, first 2 is destruction of the cells. Next is dysfunction. Third is cellular or receptor level dysfunction. It's not destruction. Fine. Okay. These 3 images are from Robbins. If I have antigen against a cell, I have a cell. Let's assume the cell is an RBC here or WBC here or platelets here, right? So I have an antigen here. It's an opsonized cell. So my phagocyte will eat the cell. Every antigen against a cell, the end point is phagocytosis. The best examples, if it's against a cell, anything you read in blood which is based on antigen antibody reaction is examples of this. Anything you read in Blood, can anyone tell me what's the disease when we have antibodies against platelets? Autoimmune hemolytic anemia is an example. Erythroblastosis fetalis is an example. Perfect, right? ITP is an example, right? Anything against a blood. Anything against a blood circulating cell, not a blood vessel, blood circulating cell, right? Anything against the surface. If it's against the surface, I cannot eat, I cannot swallow. So what happens here is, so since there's a failure of phagocytosis here it will have complement mediated inflammation. Okay, so it'll have complement mediated inflammation. So I'm having antibody against an antigen, but it's on a surface, right? Your ANCA vasculitis. That's an example. Veride portion, right? Goodpasture syndrome is an example. It's against the surface. Goodpasture syndrome is antibody against collagen, goes and sits there, has it. ANCA vasculitis kind of ends up in this only, so it has that, right? So all these are different types. Second example, right? Third is cellular dysfunction. Here what happens is there will be a receptor dysfunction. Ideally, I am not destroying the receptor, I am altering the function of the receptor. Two examples. One, myasthenia gravis. You must have read that from first year, right? You have acetylcholine receptors dysfunction, altered function. Second, your Graves. Graves, you have TSH receptor dysfunction, right? Actually, in these two examples, you are actually telling two more things. Dysfunction can be reduced function, like in your acetylcholine myasthenia. Graves, reduced or elevated function. What happens in Graves? Reduced or elevated? Graves is obviously it's hyperthyroidism, right? We have long-acting thyroid stimulators. It's an elevated function in case of Graves. Perfect. Okay, I can have both of them in case of a dysfunction, right? So these are examples of type 2, three different pathogenesis and examples of three different things, right? Perfect, right? Then type 3. Type 3 is very simple. I'm telling you the pathogenesis here. Examples, the classical example is SLE. So we read about type 3 pathogenesis based on only one person. We read based on serum sickness. Serum sickness is the place where we read about it. So when we gave horse immunoglobulin or horse serum into human beings, very long back, fine. Then Hashimoto, I will put them into type 4 primarily. See, there are few things which where type 4 and type 2 overlap. Don't write them here. Okay. If they ask you about type 2 hypersensitivity, write that classically. Pernicious anemia, type 4, type 2 overlap. Hashimoto, type 4, type 2 overlap. Celiac, type 4, type 2 overlap. Right? Don't write that here. There will be component of type 2 for sure, but there's an overlap. So examiners might think it's something sometimes wrong and will disregard them. If they ask in a waiver, tell there's an overlap for type 4 and type 2. Fine. Okay. So once we give a horse serum to a human being, so this is the horse serum. The red ones is the horse serum. My body will develop antibody. That's the first step, formation of immune complex. Second thing, this immune complex will get deposited. Deposition happens in two places classically. One obviously will happen in skin because of the hairpin shaped bend. Second, it will happen anywhere there's a filtration force. Anywhere I have a filtration force happens, that's why SLE, serosa, joint space, your kidney, wherever there's a filtration force, it gets deposited. Once it gets deposited, again I'll the same thing, complement activation and inflammation and vasculitis. Type 3 is undoubtedly vasculitis, right? Draw vertically. In an exam, if you feel that I need more space, if my teacher is going to consider space for marking, draw vertically. Otherwise, draw whatever the way you want. Most of the examiners don't want you to spend more pages because it's difficult for me to go and correct it, right? If it make it easy for me, it's easier for me, fine. So a few examples of type 3 hypersensitivity. SLE is the prototype. Though we read with serum sickness, SLE is a classical example of type 3 hypersensitivity and serum sickness, obviously. There's one kind of a localized variant of serum sickness, which is an induced experiment called as an Arthur's reaction. That also is a type 3 hypersensitivity. These both don't exist now, right? PSGN is a type 3 hypersensitivity. Here I have immune complex which are planted. Here it's not a circulating immune complex. If you want, write the difference. These are planted immune complex. So there's still a contemplation whether this is type 2 or type 3, but they come at a planted immune complex. Robbins calls them type 3. We'll go with type 3, right? PSGN, fine. And we have one arthritis, reactive arthritis. Viva. In Viva, especially be careful. Rheumatoid arthritis is type 4. Reactive arthritis is type 3. You must have read about many like chlamydia can cause reactive arthritis. It's antibody against them. Yersinia, the plague causing organism, which can cause reactive arthritis, right? All of them are will come under type 3 hypersensitivity reaction. Fine. Okay. Okay, next type 4. Fine. So type 4 hypersensitivity, two words which I would want first is it's a cell mediated hypersensitive response, because this is the only thing which is T cell mediated. There's three of them are B cell mediated. Fine. Circulating immune complex is there in circulation. In PhD, if you remember, Samantha, I have the antigens is stuck on the capillaries. Then antibodies comes and destroys them. That's why it's planted immune complex. A very narrow difference. Let's not go into it as of now. Fine. Perfect. And the second one which I want is delayed. It will be a delayed response only. These two are very important in case of a type 4 hypersensitivity. Fine. Okay. The mechanism or the pathogenesis is same thing what you read in granuloma formation. Write the same thing. Okay. It's T cell mediated, right? So T cells can have three different types of activation. TH1, I'm writing TH2 first. TH1 and can have TH17 if it's a CD4. At the same time, I can also have CD8 T cells. Right? Of this, the predominant in type 4 is TH1. TH2 goes to your allergy, IgE. We disregard them, right? TH17 can also be there sometimes. It's a combination of TH4 and TH1 and TH17. TH17 will have acute on chronic inflammation. Okay. So sometimes the combination of TH1 and TH17, sometimes predominantly TH1, sometimes predominantly TH17. It differs based on the diseases, but that's how it happens. CD8 also can happen, but very, very less. One example, if you want to add on to it, viral hepatitis. You can add on to it, but we don't consider them as hypersensitive reaction. We consider them as a viral disorder. That's all fine. But it's predominantly CD4. And this is an image. It's nothing but the same thing of granuloma, what I have depicted here. Antigen presenting cells presenting to T lymphocyte produces the activated macrophages, produces more interleukin, more activation, more lymphocyte, results in granuloma. That's all fine. Okay. Examples. Examples are important because sometimes, most of the times, especially in Viva, you might misregard and you might forget a few things. We'll write first things what you'll forget. Contact dermatitis. Contact dermatitis is type 4, not type 1. Dermatitis doesn't mean it's always allergy. Contact dermatitis, the metal ion, like in a bracelet, goes inside, antigen presenting cell goes, then after a couple of days only, I'll have this. Fine. That's type 4 hypersensitive reaction. Fine. Then rheumatoid arthritis. Okay, it's type 4. Though you must have read about rheumatoid factor and antibodies to citrullinated peptide. I will have antibodies, but it's type 4. Most of the type 4 will have antibodies. Type 1 diabetes is type 4. Psoriasis is type 4. Okay. Inflammatory bowel disease, especially ulcerative colitis, is type 4. I'm writing ulcerative colitis for the reason Crohn's also is type 4. I'll tell you why I'm writing ulcerative colitis. In these both, TH17 is a little bit high. That's why did we read about cryptapsis? No, Samantha. Atopic dermatitis, atopy is allergy. That's type 1. Contact dermatitis, type 4. Fine. So in both of them, you'll have TH17 more. That's why in case of psoriasis, there's an abscess called as an Monroe's micro abscess. Though it's an autoimmune condition, chronic inflammation, you'll have neutrophils. That's why in ulcerative colitis, we have cryptapsis. It's neutrophils. So whenever TH17 is more, like I said, TH17 will cause acute on chronic inflammation. You'll have neutrophils more. That's by default. That's how it will happen. Fine. So whenever TH17 is more, I'll have neutrophils along with the classical inflammatory infiltrate and well-defined or an ill-defined granuloma formation. Fine. That's for type 4. So if you're still there, I hope you have a quick revision of hypersensitivity as well. Fine. Last but not least, let's go to graft rejection. Grafts, I'm not sure. Quite a few of your seniors and you guys, when you share papers, graft has not been asked commonly in exams, right? It's mostly your hypersensitive reactions, easy ones is what they ask. HIV comes, but graft Very, very unlikely. Did any of your previous year paper have graft in them? No, not here. In inflammatory bowel disease, Samantha. In ulcerative colitis, right? If they ask, great. If they're not asked, let's quickly revise it. Let's not leave it, fine? So in case of grafts, I have two problems, right? One, which happens in solid organ transplant. The problem in solid organ transplant is rejection. Be it a kidney, be it a liver, be it a heart, rejection is more important, right? Perfect. One, which happens in hematopoietic stem cell transplant, like ABC said, it is GVHD, graft versus a host disease, right? GVHD is more important, right? So because this is deadly, graft rejection is more of a postgraduate or super specialty problem, right? Hematopoietic stem cell transplant and few other places which you'll see soon, I'll have graft versus host disease, and rejection is more common in solid organ transplant, right? In rejection, I have three subtypes. I have hyperacute, I have acute, and I have chronic. That is in rejection. In GVHD, I have same acute and we have chronic. That's what happens in case of GVHD. Acute and chronic. In here, I have three types: hyperacute, acute, and chronic. Fine. One important thing, never forget, graft is not an innate immune response. It's always an adaptive immune response. So will there be any component of neutrophil coming inside? Never. Though I call it acute, it's always T cells and B cells. It's never ever neutrophils. It's always an adaptive response. It's either antibody or a T cell, never neutrophil in case of graft rejection. Even it's acute, it's never neutrophils. Fine. Let's go to hyperacute. Hyperacute happens within minutes of the transplant being done. And the reason is formation of donor specific antibodies in the host. Right? So the host, if I am the host, I already have donors antibodies, right? So why there's donor antibodies? One of the few examples is when there's an increased parity, multiparous women, when there's very, very high amount of blood transfusion, right? Or if there is a person who is already a previous transplant has been done for the patient, right? So in all these conditions, what happens is there is a chance, I'm not saying always, there's a chance I can have donor specific antibodies, which means I'll have antibodies against the kidney which I'm getting, right? So let's assume if this is formed, what will happen? So the pathogenesis is simple. After or immediately after anastomosis, when I say anastomosis, which is between the graft and the host, the blood supply, I'll perfuse the kidney, right? Immediately after anastomosis, the donor specific antibody will go and it will bind to the endothelium of the graft, because endothelium is donor and my serum already have antibodies to donor, right? Once it binds to endothelium, it will cause endothelial damage. Whenever endothelial damage happens, what will happen? Clot. You'll have a clot which will stop the perfusion. Once it stops perfusion, can I say it will cause necrosis? Kidney is a solid organ. What type of necrosis? Perfect. Coagulative necrosis. So it will undoubtedly destroy the kidney immediately within minutes of transplant, right? So once I have coagulative necrosis, look at the image. This is an image from Robbins. Tubules, no blue color, only pink color. Glomerulus, no blue color, only pink color. So even though it's dead, this is dead or alive? Anyone? This glomeruli and kidney, dead or alive? Definitely is dead, right? Even though it's dead, can you identify its glomeruli and tubule? You can. Architecture is maintained. Ghost cells are present. It is coagulated necrosis, right? So whatever we read will come into a circle, right? So definitely this is the pathogenesis which will be there in case of a kidney, fine, immediately gone. To prevent, I have a test called just to test the donor specific antibody, something like cross matching. We do that, fine. Something like cross matching. We have to test for donor specific antibody in every host. If the antibody levels are present, then I will reject the patient. They are not eligible as a donor. It's something like cross matching. You just write this test for donor specific antibody like cross matching, right? That's hyperacute. Acute graft rejection, happens at the end of a week to few weeks. It's not very clearly defined because chronic happens after months and years. So anything which is not happening immediately will put under acute, and they are lymphocyte mediated destruction only, right? So etiopathogenesis, two things happens here. So here, let's assume I have a donor. I have a kidney of the donor. This kidney will have nucleated cells. Obviously, they'll have nucleated cells. And this nucleated cell, again of the donor, will have MHC1. So this MHC1 is considered foreign. It's foreign to the host CD8. Obviously, they cannot bind, right? So then they'll consider foreign. So CD8 will cause direct toxicity. I'm sure you know how CD8 causes toxicity, perforate granzyme and destroys. Because this is a donor's MHC1. MHC is very, very specific. Your MHC and my MHC is not the same, fine? Then I'm not understanding your question. What do you mean by re-exposure? See, this antibody is there in the, let's assume I got a kidney. Antibody is with me. When I get the kidney will have the donor antigen, right? So my antibody will keep on binding to every tissue, every endothelium and keeps destroying them, right? That's what happens. And once I have the endothelial destruction and clot formation, that clot will cause necrosis. Okay? The clot of the endothelium will stop the perfusion, which causes necrosis, fine? That's one. Okay. So second thing is, so my antigen presenting cell of the donor, of the host, will present the donor antigen to my CD4. So once CD4 meets with any antigen, you know the fate, right? It's obviously going to cause destruction. By more and more interleukins will be there, and lots of macrophages also will come into play, and obviously this will cause destruction or damage. Okay, so there are two ways by which my T cell can destroy it. Because of no blood supply, Samantha, preformed antibody is like I have an antibody to a person who is a donor. I'll give you an example. Let's assume I'm giving my kidney to my mother. My mother would have exposed to my antigen way back when she was pregnant with me. When RBC can cross, antigen can cross. So there's a chance her body can have antibodies against me. So I'll test for that. If there is antibody, I am not an eligible donor. That's why multiparity, multiple transfusions is a risk of presenting preformed antibody. Fine, Aniket? Host CD8 is my CD8. My CD8 will consider this donor MHC1 foreign and destroys them. Okay. And by the way, when this damage happens, there's definitely a possibility there'll be more antigens in circulation. This will trigger B cells to produce antibodies to them, and that also will kill the donor, right? So two things, only T cell and B cell. T cell acts as CD8 or CD4, and once CD8 and CD4 destroys, circulating antigens will definitely come. B cell produce antibodies to them and definitely will kill the host, right? This is the mechanism of acute graft rejection. I have two types: acute cellular, acute humoral. And in cellular, I have tubular, interstitial, and vascular. Microscopic finding is not required. If required, it's very simple. I'll have lymphocytes in interstitium and tubules. Here also I'll have lymphocytes in the blood vessel wall. Okay, you'll have in the wall of the vessel, you'll have lymphocytes, not in the lumen. Lumen lymphocyte is normal, wall lymphocyte is abnormal, right? Vascular, what happens is, I'll have antibody, let's say, against endothelium. So if I have antibody against endothelium, the antibody binds to the endothelium. They'll not directly destroy. Whenever antibody is there, can I say it will attract complement? Obviously, right? It will activate complement. So that I'll have complement activation, and that will cause vasculitis or vascular damage. Humoral rejection will not have a tubular interstitial subtype. It's only a vascular subtype, right? This is what is required for me, because in IHC or an immunofluorescence, to diagnose them, we have C4D. If C4D is positive in case of your peritubular capillaries or vessels, I'm going to think in terms of an acute humoral rejection, fine? I'm not saying not. I will test Vemish. Let's assume I want to give. They will test my my mother's serum and my antigen, like a cross matching what happens in blood group. If there is a reaction, I'll not donate. That's all. There's no reaction, I can donate. Right? There's a risk, that's all, fine. Here, C4D will be negative in case of an acute cellular, fine. Okay, that's about acute rejection, just in few words. Chronic rejection, it's something which happens very late and it's inevitable. We cannot stop it from happening. Chronic rejection, the problem is repeated vascular damage, which results in graft arteriosclerosis. Sclerosis means thickening, right? So what happens here is there is repeated vascular damage due to antibodies only, right? There's repeated vascular damage. This will result in repeated thrombus. Can I say if I'm having repeated thrombus, one of the outcome of thrombus is organized thrombus? It becomes organized. That organized thrombus will reduce the lumen of the vessel like anything. Once the lumen reduces, I'm going to have tissue destruction, healing by fibrosis. That's the problem with every chronic inflammation, right? The tissue destruction and healing by fibrosis, which will destroy the transplanted kidney. So this will definitely happen. Some lucky people might not happen for 10 years. Unlucky people can happen in a year. Once this happens, it's useless, that's all. Ramesh, just a question. If RBC can enter the mother, won't WBC enter? Yes, no. Yes, right? Platelets? Definitely yes. If WBC and platelets can enter, will MHC complex enter? It will. My problem is MHC, right? So the HLA or some antigen, I'll have definitely antigen entering. If RBC can enter, definitely antigens can enter. So I'm not saying always it will, but there's a chance there can be a rejection, that's all. So we cross react, we do the test. If it's reacting, I will stop. Otherwise, I'll give. We'll be more than happy to give. That's it, fine. Okay. There's a microscopy where you can see the lumen is reduced to anything. That's a lumen, and the entire thing is the graft arteriosclerosis. It's completely thickened and destroying it. Fine. Okay, got it. Then we'll go to GVHT. Fine. So GVHT is common in exam. So if it repeats, GVHT is a very unique phenomenon where when an immunologically competent cell like a bone marrow or spleen or small intestine, fine, Piyush, ignore. We for IHC is there for every bacteria. H. pylori has own IHC. IHC for TB is tuberculosis antigen IHC. That's all, right? If they have asked you, only two reasons. One, you have done very well in your Viva, so they have to ask something so that you don't answer, or the examiner is not good, right? Both the things are not under your control. I hope it's the former. Then you have answered very well. For everyone, if they ask questions like this, H. pylori has an IHC. Syphilitic treponema has an IHC. All these are bacterial antigen surface IHC. That's all. Fine. Okay. We'll come back to this. GVHD occurs when an immunologically competent cell or their precursors are transplanted to an immunologically compromised recipient, right? So where all GVHD can happen? One of them common is hematopoietic stem cell transplant. It can also happen in small intestine. Because I'm sure small intestine, you know that there's a good amount of Peyer's patches. Peyer's patches have a good amount of lymphocytes, right? That's why it can happen, and very rarely it can happen in splenic transplants. Though we don't do a splenic transplant, we don't worry about it, but theoretically it can happen because spleen is also it's a part of reticuloendothelial system. It happens, fine. Okay, so primarily hematopoietic stem cell transplant, right? So once we know this, we have to know a little bit about the pathogenesis, fine. So what happens is, so when you have an immunologically competent donor, we'll use the same host and graft, right? Immunocompetent graft. So this immunocompetent graft will have T cells. These are primarily T cell mediated, fine. So T cells, I divide them into CD8 and then I divide them into CD4. Okay. So IHC is anything which is done on a tissue. CD marker is a subtype of IHC. Like I have cytokeratin, it's a subtype of IHC. CD marker is a subtype of IHC, that's all, fine. So CD8 will directly destroy cells of the host because the host MHC and the graft's MHC will not match unless and until if it's an identical twin, right? It will not match, so they'll directly destroy. CD4, the same way. The antigen presenting cells will have to present the antigen. Once it presents the antigen, it will recognize them, activates macrophages. Once it activates macrophages, it will slowly destroy. This also will destroy. Again, because my HLA and the donor's HLA is not the same, and the graft is more powerful, host is weak. This is what happens, right? Now tell me, who will act first, CD8 or CD4? Who do you think will act first? CD8, CD4? Undoubtedly, CD8, right? So CD8 causes acute GVHD and CD4 causes chronic GVHD, right? We divide GVHD into acute and chronic. If something happens less than 100 days, we call it acute, predominantly due to CD8. I'm not saying only CD8, predominantly due to CD8. I have chronic GVHD more than 100 days, CD4 predominantly, and obviously when antigens and the tissue is destroying, antibodies also slowly can form, right? It's due to CD4 and antibody. Perfect, fine. So now, most of the time, CD8 is different, Samantha. TH4 will happen only in CD4, fine. There are three organs which is very, very important, both acute and chronic, which are all labile cells. Okay, labile cells are mostly damaged. The reason why labile cells are damaged is labile cells are produced every single day. So now let's assume I have a cell which is resting, no noise. The graft CD8 comes, okay, will not identify, goes. Labile cell keeps on dividing, says I'm here, I'm here, I'm here. When the graft CD8 comes, okay, this guy is there, let's bind and let's destroy. That's why labile cells are more damaged compared to one non-labile cell, but non-labile cell also will be damaged, fine. Hello, Yaqeen, neat. Assalamu alaikum, fine. Now, so we have three things: skin, that's one; GIT, that's one; and biliary epithelium. Okay, every epithelium obviously is a labile cell, right? That also will be damaged. So in case of an acute GVHD, everything is acute. Skin, what happens is we have a phenomenon called as desquamation. Desquamation means skin has been ripped off. That's desquamation, right? Thank you. And GIT, you'll have dysentery and you'll have diarrhea. That's again acute. Biliary epithelium, entire biliary epithelium will die and block the biliary radicals. So once the biliary epithelium dies, they'll block the biliary radicals, which causes obstructive jaundice. Okay, this is what happens in case of an acute GVHD. Chronic, what's the hallmark of chronic? You won't forget it, right? TDHF, tissue destruction, healing by fibrosis. Same three organs are the primary manifestations. In chronic here, I might have scleroderma, TDHF. In chronic here I have stricture, TDHF. In chronic here I have biliary cirrhosis, TDHF. Okay, so undoubtedly I'll have fibrosis in almost every organ. So chronic also same thing, but chronic is not that important for me because GVHD kills patients. Imagine entire skin, the largest organ in my body, and GIT, I am having epithelial loss and every capillary is leaking. The patient won't survive. It's a very deadly disease, very difficult to treat, and there's a way to prevent GVHD. Maybe write a word about this. Prevention is having a perfect HLA match. If there's a perfect HLA match, the grafts CD8, CD4 will not consider mine foreign. So I am same, so I won't destroy them, I won't reject them. That's the only way to prevent it. So treatment, there are few possible treatment modalities. From the graft, they try to remove T cells because they were causing the damage, right? So they removed T cells. That's one of the ways by which they tried it. Didn't work much, fine. Okay. Desquamation, it's simple, Samantha. Squamation, squamous. D is removal. I'm just removing or stripping off the entire skin. That's desquamation, fine. Okay, that's about GVHD, fine. If it comes in exam, one word for definition, where all it can happen, something about the pathogenesis, and acute, chronic, and a word about prevention and treatment. This should be more than enough for you for GVHD, fine. Okay. Yes, Aniket. Triplets, most of them are induced when they are, most of the triplets are due to artificial insemination and your IVF procedures, right? Triplets naturally happening is bit rare, but if triplets are identical, again, they are good like an identical twins, right? energy. Okay, that's all for today. If you guys can don't want, you can leave. I'll explain energy for ABCD. Okay, see, energy is a method of tolerance. That's all. Fine. Okay, so energy is a method of peripheral tolerance. Tolerance means the mechanism by which my bodies will stop reacting to my self antigen. That is tolerance, right? So a normal T lymphocytes, how they will act is, especially CD4 T lymphocytes, right? CD4 binds to MHC1 or MHC2, ABCD. They'll bind to MHC2, right? They'll bind to MHC2. And CD4 always binds to MHC2 by the T cell receptor. TCR is T cell receptor, right? At the same time, I have one more guy coming from the CD4 and my APC. We call them co-stimulatory molecules. We have CD80/86 from APC, CD28 from CD4. These are called as co-stimulatory molecules. Okay, this is normal. Fine, this is completely normal T cell interaction. So now let's present an antigen. Let's assume TB. TB is presented by my APC. CD4 recognizes TB. It's foreign. Let me go and kill TB. That's the goal of CD4, right? But for this to happen, this interaction will give me first signal. This interaction will give me second signal. Both binding should happen, right? So this gives two signals, and both signals are must for CD4 activation. This is how CD4 activates. That's why I call them co-stimulatory molecules. They are also present for me, right? Co-stimulatory molecules, right? Now let's have a look at energy, which means energy is stopping my activation against a self antigen. That's peripheral tolerance or energy, right? 80 or 86. Yes, Samantha. Or we call them B7 7.1, 7.2 molecules, 80 or 86 CD markers, right? So let's assume my antigen presenting cell, which is not an innate, adaptive immune response, innate immune response, presented by mistake a self antigen. And by mistake, CD4 is bound to it. CD4 should not bind. By mistake, CD4 is bound. So this binding will make the CD4 will definitely recognize self antigen, because CD4 is taught in the thymus, that is self antigen. Once it recognizes self antigen, it produces two molecules, CTLA4 and PD1. This CTLA4 and PD1 will make sure the second interaction between 80-86 and my 28 is being blocked. This will come and block the second interaction, right? At the same time, PD1 is programmed death 1. So it goes and kills my CD4, right? So in this way, this will stop CD4 activation because the second signal is not there, right? So this stops CD4 activation. The CD4 activation is stopped, which is good for me because there is no reaction to a self antigen. To a TB, I reacted. To a bacteria, I will react. To a self antigen, I will not react. Fine. This concept is called as energy. Fine. Okay, ABCD. What's the name ABCD? Names are more important. Okay. Fine. Great. So maybe in a couple of days we'll complete one more thing. I have to talk about a little bit about genetics, and your Samantha asked for bleeding disorders. I'll definitely cover bleeding disorders and also cardiomyopathies. Fine. Thank you, Aniket. Okay. Okay, Daksh. Superb. Fine. So all the very best, guys, for anyone who is having exams in coming Monday. Don't worry, you will do well. It's not a big deal at all. Fine. This notes will be then PW's Telegram channel. Moment. Okay. Good night, then. Yes, Samantha, you can use. Hopefully your papers are good and the pen will not reflect in the back page. If it's good, use whatever color you want. No one is going to care about it. Fine. Okay, guys. Thank you. Bye bye. Have a great night.